Today we have very important discussions, extremely important discussions. Today we're going to be talking about Dopplers, fetal Doppler velocimetry. I'm going to give just a brief hint about certain important details concerning Doppler velocimetry. And then after that, we will have one of our chiefs, our gurus from the diaspora, who has moved around the world, and he also he loves to teach. And for those who are privileged to be here today, they shall see what his teaching is like. Like I said, we're going to be talking about a very important topic, Dopplers. I'm going to start when I give my brief intro concerning it, talk about the pricing of Dopplers. And you're going to be shocked at what you are going to be getting free for the next 1 hour, what it costs. There's one that's coming up very soon in the UK, and I will show you the cost estimates for that. So today we have a long day because I've seen the slides and they are power packed. So we'll start immediately. Those who join us late, well, it's nobody's fault. When you have a webinar, try to join 5 to 10 minutes before time. I am Dr. Ehigha Enabudoso. I practice OBGYN at the University of Benin Teaching Hospital. I have a special interest in fetal maternal medicine and obstetric ultrasound scan. As I said, I coordinate the Fetal Diagnostic and Ultrasound Center, which is in Benin and has been in the forefront of ultrasound training in West Africa and beyond. Was try to attend. And we're going to be inviting experts in the field from different parts of the world. We've already done that in the last 2 weeks, and this week is no exception. At the end of today's meeting, we're going to scroll our contacts, and I'll go straight to the topic for today. As I said, it's a very important one, and there are a lot of things to discuss on Dopplers. So it's going to be very difficult for us to finish in just 1 hour, but we're going to make the best of what we can. What are Dopplers? So first, I'm going to just start by giving us an idea of what Dopplers are. They are a form of non-invasive method of assessing hemodynamics. Essentially, what happens is that we have the cardiac cycle in a human being, systole and diastole, and blood flows at different rates, especially in the arteries. But in the venous flow, remember we say you have large capacitance, low velocity, but the arteries are low capacitance, high velocity. So there are different velocities during the cardiac cycle. This is what the Doppler velocimetry measures. For us, we are more interested in that in the fetuses. It has proven to be valuable in antenatal fetal surveillance. This, Dr. Leye is going to talk extensively about. Now, what does this teaching of Dopplers and even learning of Dopplers, what does it cost? There is a training program that's coming up in the UK by ISOC sometime in a few weeks' time, 24th of July. And so I just sent an email that I wanted to host in Nigeria. I want all of us to look at what the cost estimate was there. £500. Calculate that from the present rate. That's almost getting to the salary, or let's say at least very close to the salary of a doctor. 1 month salary of a doctor. That's what you use for 1 day's training in Doppler. So it therefore underscores the fact why I say that we must take some of these things that are coming to us very seriously. Dopplers, teaching them is not cheap, but we are lucky that we're able to collaborate with many other folks around the world to teach us about this very important topic. Now, a few teasers. I tried to just start with just a few teasers. Maybe it was a classroom session, I would have been asking people specifically, but we won't have that opportunity now. So I ask here, what vessel are we tracing here? This will be easier for those who have seen it being done before. But I'm going to show this again as I start my lecture, but just to give us a hint of something to think about. This one too. Now, remember that you can chat. There's a chat on the chat platform, so you can always decide to click on the chat and then give us an idea of any of the answers that you may have to what some of the things that we have already mentioned here. So, as I said, why is this like this? You can see, you saw from the previous one, it looked fine. Why is it that this one breaks up at the top and then continues at the bottom? What is the name that's given to this? As I said, these are just teasers. Now again, one may ask, what structure is this? Why is it that you have a blue and you have a red? And just to give you info, these are the same vessels. These are umbilical arteries. So based on that, what structure will this be? I know many people are already raising their hands to answer, but these are just teasers for the beginning. Please mute your phones, mute your lines. Since I'm the host, I have to be doing so many things at the same time. So if I don't have to be muting people, then I will have more, my system will not freeze. So please mute yourselves. So what is this?
No. I know you sent it. Just transmit it up to
These are our people. Hi.
I discussed all those things you told me with my husband.
Who is this person? Cosmos Clifford, mute yourself. All right, so which structure is this? Again, to give you a hint, this is the descending aorta, and then obviously around it you have the inferior vena cava. So this should be the renal artery. So why is it that there's none here? You can easily make a diagnosis from this. Now I just decided to also show us some of the reports that we get from around our country. As I said, learning Dopplers isn't cheap, so it's difficult for people to learn it properly. And so when somebody sees a result like this, if I see a result like I'm sure Leye is also there, see a result like this, it gives you an idea of who trained the person on Dopplers. They say garbage in, garbage out. By the time you put everything, both the relevant and irrelevant, sometimes it shows that the person has not had the opportunity of a great training. So now let's just move on. We're going to see some of those slides again. So what does obstetric Doppler do? What it does is that actually gives us the varying flow velocity during a fetal cardiac cycle. Remember the fetal cardiac cycle, we said you have systole and diastole. It gives us the blood flow velocity during this whole cycle. What are things that the Doppler is able to do? It can detect the presence and quantity of blood flow. But the ones that I've highlighted here, that I'm just going to show a few slides on, I can give you the direction of flow, and that's important. You want to know if flow is backwards or forward. It can also measure the blood flow velocity, and that's why it's important as it helps us to measure the flow velocity in the middle cerebral artery and can tell us if there's fetal anemia or not. It can also help in the confirmation of certain structures, as we will see, though we've already seen some of them, but we're going to see them again. Now, this is what I showed before. What is this? There was once a patient a few years ago that had a baby with a large abdominal cyst, and we didn't know what and they didn't know what it was, and they sent it down. All I needed to do was to put Dopplers. And immediately I saw one vessel flowing in another direction and then one flowing in the opposite direction. I could tell that these were the vesical arteries or the umbilical arteries. And based on that, the structure that they surround is the bladder. And based on that, I could make a diagnosis of a posterior urethral valve with a grossly dilated bladder. So that's one of the things that Dopplers can help you to do. Another thing that I also want to show here is one very popular thing that they ask people in examinations. Which vessel is blue, which is red? And so many people confuse it to think that blue means vein, red means artery. Not exactly. What you look at is to come here and look at this. If you look at this area here, you will have the red up or here orange, and then the blue down. It therefore means that any flow towards the probe will usually be here, around here, when you are scanning the woman. Any flow towards the probe will show this color. So it therefore means that this is a flow towards the probe. This other one is a flow away from the probe because the probe is up here. So you can always look at this map, and based on that, you can tell the direction of flow. Now, the same thing here. We are measuring the umbilical flow here, umbilical artery flow. So sometimes one may ask, why is it that this sawtooth appearance, which is the appearance of the umbilical artery, is down? It is because it is measuring the gates. This is what is called the gates. Two lines there. It is on the artery, which is flowing away from the probe. And when the artery is flowing away from the probe, the sonogram that you have will be in the opposite direction. But also something here just to mention. So as I said, there's a lot to learn in Dopplers. It could take weeks to learn Dopplers. So today we just have a short time, and I know we're going to have a part 2 of this presentation. So I'm just highlighting a few things that sometimes people make mistakes with. What is this? So in this, because the gate goes across artery and vein, you have the venous flow and the arterial flow. The arterial flow shows this characteristic sawtooth appearance. So a saw, and you know the tooth of the saw. And then this other side is supposed to be uniform. However, you can see that it's undulating. This tells us that the baby is breathing. And if the baby is breathing, is that baby doing well or not? If you think that the baby is doing well, do it with a show of hands, please. Let me see how many people think this baby is doing well. Let's see their hands up. You can always use the system to show that your hands, 3 participants have their hands raised. So only 3 people think that this baby is doing well. Okay, 4, they're increasing. 5, oh, they are increasing. It shows that this baby is doing well. So just looking at this can tell you that this baby is likely to be doing well. Now again, what is it that Dopplers can also help us to do? This was an image that was sent to us by one of our great guys, Dr. Leye from Ehigha. This, as I said before, is a descending aorta. And then from the descending aorta, you now have the renal artery branching out, and then the renal vein going into the inferior vena cava. You're supposed to have the two of them. It's like a cross. But in this case, he noticed that when he put the Doppler, it was only on one side, so he didn't see the other. So he now looked very well and realized that this kidney was absent. So you can see what Dopplers can help you to do. Can help you to make a diagnosis of a unilateral kidney. So those are some of the teasers, and I just said we should start with some of them. Now, what are the common obstetric Dopplers? It's also good to know there are so many vessels that have been studied, but only 4 of them have great clinical utility in obstetric and fetal medicine practice. The first one is the uterine artery. The second one is the umbilical artery. The third one is the mesocerebral artery. And then the fourth one is the ductus venosus. Also, there's also the 5th one that is the umbilical vein. So somehow they just blend it along with the ductus venosus. So it's important to remember these ones. Now, what are the commonly used Doppler indices? One of the commonest ones is the pulsatility index. The other one is the resistive, sometimes called the resistance index, RI. So you must have heard PI and RI. There's also this old one, easy to calculate, but has become, it's no longer really as common as it used to be. So, somebody is still disturbing us. Okay. So, the systolic diastolic ratio, but it's no longer really that common. And then we also have the peak systolic velocity. Each of them has a different utility. So if somebody does an umbilical artery Doppler and gives me everything, once I see the results, I just laugh. I say, okay, this guy only learned how to do the Dopplers, but he didn't learn what the Dopplers would help us to do. So for umbilical artery, the one that's important to us is the pulsatility index. and the resistive index. For middle cerebral artery is the PI and the PSV. As I said, SD ratio is no longer really that common. So why do we do Dopplers? Now, for those who are new to Dopplers, these and the next few 3 to 4 slides before I switch over to our chief, Dr. Leye, are very, very important. As I said, this is Dopplers made easy. What is the clinical essence of our doing obstetric Dopplers, fetal Dopplers? I have said that there are 4 major Dopplers that we do. The uterine artery Doppler, umbilical artery Doppler, the middle cerebral artery Doppler, and then the ductus venosus. Each of them helps us clinically for a different purpose. The first one is the uterine artery Doppler. It helps in the assessment of uteroplacental circulation. I will explain this a little later. It's going to be made easy for those who are seeing Dopplers for the first time. For the second one, umbilical artery assesses the fetal placental circulation. Important, I will also explain it. And then the third one, assessment of the fetal hemodynamics, the middle cerebral artery Doppler and the ductus venosus Doppler. So remember this. But as I said, we're also going to have this lecture on our website. So it's being recorded and we're going to upload it in the next few days. So you can always go there, or I can see that a lot of persons have come in late. Almost 70 persons have joined us after we started. So you can always go to our website and then you listen to the lecture again. So I've already talked about this, the common obstetric Dopplers. Now, as I said, I'm going to explain each of these. I'll go back a little bit and mention it again, and then we'll go and explain them using those diagrams. We said uterine artery Doppler. So there are 4 major Dopplers. Uterine artery Doppler helps us in the assessment of uteroplacental circulation. Umbilical artery Doppler helps in the assessment of fetal placental circulation. They are different. This is from the uterus to the placenta. After the placenta, you now have placentofetal or fetal placenta. Now, when it has reached the fetus, you now move on to the others to assess the fetal hemodynamics. So now let's start with the first one. This is a uterine artery. It divides into all those spiral arteries, arcuate arteries, and gets to the placenta. Therefore, when you do uterine artery Doppler, what it does is that it gives you an idea of the impedance to flow from the uterine artery to the placenta. Therefore, if there is resistance to flow to the placenta bed, uterine artery Doppler will pick it up. So you don't use umbilical artery to tell us where there's impedance here. It is a uterine artery Doppler that will tell us about the impedance. I think Dr. Leye will also tell us an advancement of what this may do, how you use it in screening. But just know that when you do uterine artery Doppler, so when at 38 weeks somebody does Doppler and tells me uterine artery Doppler, I start wondering, this person needs to come to Benin for our training program, because uterine artery Doppler at 38 weeks, why tell me about impedance any longer? At this time, I want to know about the baby. So that's for uterine artery Doppler. Now, once the blood has reached the placenta, it now moves on from the placenta to the cord of the baby. So we'll now move on to the next one. This is the placenta. So uterine artery has supplied this. So we use uterine artery Doppler to know about the impedance. Now, when it has reached the placenta, from the placenta, it now gets to the baby through the umbilical vein. And if I may ask, how many umbilical veins do we have? 2 or 1? If you say 1, let me see your hand up. So those who put their hand down are the ones who think that there are 2 umbilical veins. The eyes have it. So there's 1 umbilical vein and there are 2 umbilical arteries. So when we do the Dopplers of the umbilical artery, what are we trying to find out? We're trying to find out about the flow. We're interrogating the flow between the placenta and the baby. That's what umbilical artery Doppler does. So it tells us, is there good flow between the placenta and the baby? So when it is abnormal, It therefore means that the flow between the placenta and the baby is poor. And if that is poor, then it gives us a risk that the baby may be in jeopardy. So that's for umbilical artery Doppler. After that, we now have the middle cerebral artery Doppler and the ductus venosus. Those ones tell us how the baby is coping with this abnormal flow. So based on that, if somebody decides to do Doppler and he goes straight to go and do middle cerebral artery Doppler without telling us whether there's an abnormality between the flow to the baby, I wonder. The only reason why that would be useful is if your tumor is rhesus negative and you want to test for fetal anemia. If not, and maybe you think that baby is poorly grown and you are checking for fetal distress, then you need to know that this is abnormal first. Once that's abnormal, you want to see how is the baby coping with it. So based on that, I'm going to ask a few questions next. Which is most important when you are looking at an economy? Let's say the Nigerian economy now. Which is most important? Is it the economic forecast as WHO and United Nations and World Bank they are forecasting right now? Is it the decreased foreign reserve? For you as a person, as a family, which is most relevant to you? Is it your reduced bank account? Is it the reduced food at home? Or is it the onset of signs of malnutrition in your family members? You can use the charts and then maybe we'll look at that later. But it's important for us. This is the same thing. What I'm asking you now is what gives you an idea of why we do Dopplers. For economic forecast, that's like the uterine artery Doppler. So you know Nigeria will tell you, oh, foreign reserve. So people ask, how does it concern me? Foreign reserve, yet my salaries are not being paid. You get it. It's not as important to you. So poor economic forecast, yes, it's good. It only tells us that there's a risk of economic problem, but it does not affect you personally as much as the other. Decreased foreign reserve, some people say, so what, not today. However, it starts to affect you. So all these first two are like uterine artery Dopplers. They set the tone for a possible problem. Then reduce bank account. You go to your bank account, you see that, man, the money has reduced. Is that enough for your family to be in jeopardy? I don't think so, because it now depends on how much you have at home. Therefore, this reduced bank account may be like the umbilical artery Doppler. It tells you, boy, be careful, oh, there's reduced things coming in. Salaries are not being paid. Your bank account has gone down. Beware. But it doesn't yet tell you that there's a big problem. When you now get home, I say, serve me my lunch or dinner. They say there's no food at home. You know there's a problem. That's where the middle cerebral artery now starts telling us there's now redistribution. There's a problem. When all of a sudden you start seeing some people in your household having malnutrition, and you don't need forecast any longer. Now you know it has come to roost in your house. That's the same thing with the ductus venosus. It now tells you, oh, well, yawa don't gas, there is problem. We must do something. So this essentially sets the tone. I am going to stop here because I know that Leye is going to do justice to a lot of some of these things that I've already talked about. So I'm going to quickly just introduce Dr. Leye now. But I know that questions will be already there, so I'll go through them while he's giving his lecture. So permit me to introduce quickly Dr. Leye Thompson. If you know him, you know that he's a full-blooded Nigerian, but he has left this country years ago, but he still has Nigeria at heart. And that's why we're always happy to welcome him. He's an obstetrician gynecologist with all the degrees that you can find, FWAX, FRCOG, and many others. The clinical lecturer also formerly works in the UK, but just like they are poaching Nigerians, the big guys from the Middle East came and pushed him away, and so he has moved over to Doha, probably for a time. and he's doing a lot of great work in Doha. He has keen interest in perinatal medicine. He loves teaching OBGYN. Actually, don't envy those who have not been to our program in Benin. Leye has come to be with us since 2015. Every year he has come in since 2015, and he always leaves a mark. It's my great pleasure today to welcome for his lecture Dr. Leye Thompson. I'm going to ask him to unmute himself, but let me quickly just put up his slide. Okay.
I'm unmuted and
Oh, great.
I need to share my screen.
Yeah, probably I'll just share it from here. I found that it's a bit, seems to be a bit
Okay, you
difficult.
disabled it.
Yes, I disabled it before the beginning of the meeting, so now it's, let me see. Okay.
Still disabled.
Yeah, well, maybe I'll share the screen from here. Good. So I'll share the screen for you. I'll be scrolling on the screen, so I think it makes it a bit easier. So I'm switching over to you, Dr. Leye. Feel free to fire on. Let me mute myself and so me too I can learn.
Okay. I wonder if all can see my screen still. It still says the host disabled. Something happened. I don't know.
Please let me on that phone.
Okay. Okay, can you hear me?
Yes, I can hear you. I'll scroll from here, so just go on.
And can you see my screen?
Yes, your screen is live and clear.
Unfortunately, I'm on full screen, so you have to tell me. I can't see you. You have to tell me if it's showing clearly. So we're just talking about yes. All good.
Clearly. So why not just you just go to the Zoom platform and then just be seeing the screen here. So I'll be scrolling it for you.
Okay. We're talking about clinical application of Doppler ultrasound, and I have to do this in a remit of 9 minutes.
No. I've given you a few extra time. That's why I have to rush through mine. So you have extra time. I saw your slides.
Extra 10 minutes.
Yes, I saw your slides. They were beautiful. So I decided to step down a lot of mine.
Sequester some more time.
Yes.
Okay.
So you have
what are we
25 minutes.
What are we doing with these Dopplers that we are all trying to learn about? Basically, what we're doing with Doppler assessment are two things. The objectives are two. One is to prevent stillbirth. The other, to prevent neurodevelopmental problems. This we can only do in babies that we know are at risk, because it's not a very good tool in low-risk populations. Okay, if we look at the global scene, every year you hear people chanting the same story. 350,000 women dying from complications of pregnancy and childbirth. And they name some specific countries: India, Pakistan, Nigeria, Afghanistan, Ethiopia, Congo. The reason why these are all happening are not because there's no healthcare, but because there's a lot of ignorance, awareness problems, communication, transport. So are Dopplers going to help? Of course they will help. They will help if we use them properly, because we can screen with Dopplers, we can treat with Dopplers, we can monitor with Dopplers. If you look at stillbirth in developing countries, I discussed this before in Benin, and you look at the clusters of problems caused and the areas causing the problems: maternal, fetal, placental, intrapartum problems causing stillbirth, you find that actually for us in developing countries, that last sector, the unknown, seems to be higher than anything else. So for today, I'm just going to stick to three things. I want to quickly look at the evidence for Dopplers. I want us to put on our thinking caps and look at the indications, the frequency of our examinations, and how we time our examinations, and see whether there's any differences in how we're thinking after listening to this and how we used to think before this. Dr. Enabudoso has kindly started us off in compartmentalizing Dopplers. When we start using the tool properly and doing what we should be doing, we should be thinking in different compartments and then putting the jigsaw together to make a proper diagnosis and plan for treatment. So why are we using Dopplers? You can use the Dopplers for screening. As you know, the ductus venosus is a very important vessel in screening for aneuploidy, particularly trisomy 21. We use it in screening for preeclampsia, and I use it at any gestation. I pointed this out again in Benin, that even though we screen between 18 and 23 weeks by convention, you can still screen at any stage with the uterine artery Doppler. We can use this in prediction, particularly in congenital heart disease. If you're good with Dopplers for fetal echocardiography, it is a fantastic tool for predicting those babies that will need immediate attention at delivery. And like some of the hospitals where we are, we have to transfer babies out. It tells you which babies you can keep and which babies you need to get out in utero. For monitoring, IUGR is perhaps the biggest condition that we utilize Dopplers for monitoring. We need it for timing delivery, particularly balancing the risk between prematurity and intrauterine fetal death in babies that are growth restricted. And for diagnosis, fetal anemia, organ agenesis, it is a very useful utility. Now, there are two ways of looking at your Dopplers: the spectral waveform and the color-coded waveform. The spectral waveform allows you to assess flow at specific sites in the circulation. And it also gives you an index of resistance to blood flow. I say an index because this is not the true blood flow or the true blood velocity, but it gives you an indication of the impedance or resistance. The color identifies target vessels for you, and it helps you tell what direction flow is. Someone asked the question earlier on just now that she thought that blood flow is only in one direction with Dopplers. No, it is in every which direction. But we view it in two ways because of the way the crystals are aligned. The blood is either flowing towards your probe or away from your probe. And you color code it. You can change the color coding to what you want. You color code it according to whether it is flowing away or whether it is flowing towards. By convention, blue means it's going away, red means it's coming towards your probe. Now, let's think a little bit about use of fetal Dopplers. Adaptation being the key to survival. And this, people used to think was Darwin that said this. It wasn't. It's a gentleman called Leon Megginson in America, a very great academic, and he said it isn't the strongest or the most intellectual of the species that will survive, but the one that has the power of adaptability and adjustment to the changing environment in which it finds itself. And of course, I look at it differently. I say it is not the strongest or the most intellectual that survives, but the one that we as physicians will appropriately select for delivery if it can't adjust or adapt to the postal environment in the womb. What is the evidence? Well, when you look at publications on uterine Dopplers from 1952 till last year, you can see the meteoric rise, the increase in Doppler publications. This tells you that this is a technology that is just beginning to find its feet. There was nothing before the mid-1960s, and after Doppler gradually gained ground, and there's an acceleration in the 2000s. Okay, why is this important? This is important because you don't have a tool that you do not understand, and yet we all clamor to learn about. What is the evidence? If you look at what Jaco and his colleagues did in terms of reviewing fetal ultrasound use, as I said earlier, they limited this to high-risk pregnancies because majority of the research publications for that had focused on everything and found that it seems to be more useful with high-risk pregnancy. And they looked at fetal and umbilical Dopplers. The main study comprised 19 trials with just over 10,500, just over 10,500 women. There was incomplete reporting. There's quite a risk of bias. They calculate the degree of risk of bias in these trials. Therefore, it was difficult to assess accurately. And unfortunately, there's no high quality evidence relating to the primary outcomes. Remember, I mentioned to you what my primary outcomes would be if we could achieve those, is to stop stillbirth and to completely eliminate neurodevelopmental problems. There was missing information, imprecise risk estimates, and there was quite a bit of heterogeneity, but not enough to worry. There were 18 studies that compared umbilical Doppler versus no Doppler or CTG. CTG being cardiotocography. And there was one recent trial by Ehigha that compared Doppler Velocimetry with computerized CTGs. And the results are that in high-risk pregnancies, umbilical Doppler will reduce your antenatal admissions, it will reduce your unnecessary inductions of labor, will reduce your cesarean section rate, and it will also influence your degree of risk of neonatal acidemia, which is important. However, it's not as useful after 35 weeks because the umbilical artery bed is so expansive there that it will take a lot of destruction to create an impact. And it scores a tick because it improves perinatal outcome. Okay, let's look at the MCA Dopplers. Again, in high-risk pregnancies, when it is abnormal, it's associated with an increase in cesarean section rate after induction of labor. Are you with me? Are you all with me? Yes. Okay. Okay. Now, there are poor neurobehavioral scores at 2 years of age. This is one of the Dopplers that people have looked at beyond delivery, because ideally we should study these children up until middle school age, 11 years, 17 years, possibly up to university level, to see what we're doing and whether it is useful or not. The lowest PIs, this is important, were seen in babies 2 weeks before the CTG, before this cardiotocograph even begins to show any problem. So actually, it is predictive earlier and at a stage when it's useful for us. Remember, I'm going to tell all of you that our cutoff point, which we should stick to, is 32 weeks, because for early and late, for early, 32 weeks. 32 weeks because the most impact we have in our management, in our looking after these babies, starts from that stage. Now, we have to be cautious when we're looking at MCA Dopplers because it may appear normal in very severe cases with something called, it's like a recovery, pseudo-recovery phase with worsening hypoxemia. Anyway, it also, at some times, will appear to show redistribution when there is not. So it is one of those Dopplers you have to be very, very careful when you're taking, and I would counsel that we all have very, very good practical training in MCA Dopplers before we start assigning significance to it. Interestingly enough, overall, it doesn't get a tick like umbilical Dopplers because it could not demonstrate a significant benefit in perinatal outcome. Now, those of you who've come to Benin know that I always say that absence of evidence does not mean there is no evidence. It just means that it has not been demonstrated, okay? One other issue which we could look at is something called the cerebroplacental ratio. which we see late in pregnancy. This is the ratio, or your umbilical placental umbilical cerebral ratio. This is the ratio of your umbilical artery PI to your middle cerebral artery PI. It is predictive of poor outcomes with a higher sensitivity than either of these indices alone, especially beyond 32 weeks, and most especially beyond 35 weeks, for those reasons we mentioned. Now, the start of significant use of the middle cerebral is from about 27 weeks. Before that, you have to be really, really good at them to be able to use them properly, particularly when we're predicting fetal anemia, because there are several things you have to correct for and make sure they are all the several parameters that you have to constantly keep adjusting to get the best and most accurate measurements possible. It's still very controversial, this issue about the cerebroplacental ratio, and no improvement in perinatal outcome has yet been demonstrated. We can look at the other sides. I did a lot of work with the thoracic aorta, which is a very reproducible vessel to use because it's a wide vessel. The thoracic aorta and the uterine artery are quite good because they're quite wide. Most of the other vessels are not that wide. We've tested it in IUGR and in fetal anemia. It correlates with neurological outcome, which not many of them do. However, again, there was no improvement shown in using it in perinatal outcome. The aortic isthmus is another reproducible level of the vessel, and it shows some degree of correlation with neurological outcome. However, technically, not everybody can pinpoint it accurately, particularly with the moving target, the fetus, and it doesn't also show any significant improvement with its use in perinatal outcomes. The umbilical vein is a very important organ. And I think in our environment, it's one that I should remove this too late for clinical utility because actually we do see it. Pulsation of the umbilical vein is a very important pointer of late and poor prognosis. There's something called the myocardial performance index, which every year something new comes out about. People have been trying this for decades, but it isn't simple enough yet for all of us to use it. And therefore, because of the poor reproducibility, we wouldn't consider it. Overall, all these other Doppler sites, no significant impact in monitoring. Finally, the ductus venosus, as I said, it may not show significant improvement in perinatal outcome. I'm starting from the bottom, but in your first trimester Dopplers, which you have to exercise caution when you're doing them, this is one of the important vessels because in screening for chromosomal abnormality, it's quite a useful vessel. In later pregnancy, it shows up fetal impairment slightly later. It is useful in monitoring in IUGR, and it may predict intrauterine fetal death, but it's not that significant in predicting neurological morbidity. It gives warning hours to days before the baby dies. So it is most useful in the late second and early third trimester. Again, we haven't demonstrated significant improvement in outcomes perinatally overall. So in summary, we've looked at clinical application of Dopplers, looking at all those vessels. I haven't included the uterine in those. I've looked at the fetal compartments, if you look at this carefully. And number one, umbilical artery Doppler reduces risk of perinatal death. So at the moment, it's the most useful tool we have. And luckily, it's the easiest of the whole lot to identify and measure accurately because it doesn't require as much correction as all the others. It also reduces our obstetric interventions significantly. They will always tell you results should be interpreted with caution because the quality of the studies are limited. Now, there's no parallel for middle cerebral artery Dopplers when it comes to diagnosis, monitoring, and treatment of atypical antibodies, fetal anemia, and growth restriction. So this is, in summary, this is what we would conclude for today. Now, my speaking time ideally should have been up now, but I will continue. I've spoken about the doctors, and monitoring of Doppler changes with doctors may be beneficial, but we need a lot more study on this because, particularly with neurological development, the evidence is inconclusive. Okay, let's look at waveforms. There are two ways of assessing the wave or of assessing Dopplers. One is qualitative, and the other is quantitative. So you can look at the characteristics of your waveforms, and from that make some important assessments. A long time ago, as you can tell from the age of this slide, it was demonstrated that in terms of umbilical Dopplers, when you have them classified into three types of waveform. Class 0, when there's continuous forward diastolic flow. Class 1, when the PI is slightly higher than it should be, and there's continuous forward flow. And the class 3. I don't want to take us away. I don't know whether you can see 3 on your board, but in any case, with class 3 waveforms, perinatal mortality increases 45%, which means nearly half of babies, by the time you're getting class 3 waveforms, there's a significant risk of intrauterine fetal death within hours. And this is just qualitative. So qualitative signs, you look at your diastolic flow, positive, absent, reversed, post-systolic notching, okay? Or you can look at your quantitative, which are those things that Dr. Enabudoso has mentioned. S0 ratio with his countenance. Resistance index, we argued for a long time that it's a useful index because statistically, the statisticians we worked with showed this to be so. However, in practice, pulsatility index is a useful enough index for us to continue to use. It is reproducible and we can compare globally when we use it. Now let's have a quick look at what happens with fetal Doppler measurements through gestation, first, second, third trimester, and in post-mature or post-dated pregnancies, okay? If you look at the umbilical placentation, umbilical artery, umbilical vein, in the early stages, the top panel shows you there's normal impedance to flow, and there's a normal pattern of pulsatility of the umbilical vein. So this is one exception to the rule with the umbilical vein, that you are allowed to have pulsatility in the first trimester. And if you look at the panel on the right, this is just a chart that shows you the trends as gestation increases, okay? This is demonstrating what I said about the PI and the reasons why we elect now to continue using it, because it has a linear relationship with the resistance. It does not approach infinity, and the standard error decreases unlike when you're using the other parameters. Let's look at the uteroplacental circulation. Dr. Enabudoso mentioned about it, and he mentioned about impedance and about how this actually starts to tell you that, like, IMF conditionalities were being suggested to us many years ago, that there's a problem ahead. But it is variable. It depends a lot on gestation because the flow changes, the pattern changes. So it's both a qualitative and a quantitative Doppler to use. And those of you who have been to Benin appreciate this from the lectures we've given and the talks we've had about it. If you look at it through normal pregnancy, in early pregnancy, this waveform is normal. In later pregnancy, it is not. Towards the end of pregnancy, it is definitely abnormal. And the normal impedance to the flow, as it reduces towards the end of the pregnancy, you find filling of your protodiastolic area. And this again is a chart that tells you, somebody again among the participants asked about normal values or the normal range for uteroplacental Dopplers, uterine Dopplers. This is it here, and the reference is there, so you can always refer to this. However, as I said, it is both qualitative and quantitative, so you can use it either way. Same with the middle cerebral. The middle cerebral also pattern qualitatively changes with gestation and quantitatively changes with gestation. And this is the chart on the right-hand side that tells you about the resistance indices. However, remember that when we're looking at fetal anemia, we're not looking at resistance, we're looking at what? We're looking at velocity, the time average maximal velocity. And that is completely different. I haven't included much talk about that in this discussion today because we're a bit restricted in terms of time. So the middle cerebral is good because it tells you when there's impairment early, and it gives you, I'm reiterating this again, that it gives you warning well ahead of cardiotopographs that we use. We've spoken about the aortic isthmus, the aorta, descending aorta, the ductus venosus, and all the other aspects of it. This is the trend with the ductus venosus during gestation. Again, you can see that this is the vessel which is a very high velocity, high flow, as you can tell by the degree of aliasing vessel. However, as with a lot of the fetal vessels, the impedance relaxes towards term. It's a late sign of fetal impairment. It's useful in monitoring growth restriction or deterioration in the second and early third trimesters, but beyond this, it is doubtful. The clinical relevance is in predicting hypoxemia or acidemia and predicting fetal demise. It doesn't tell you much about neurological morbidity. We've spoken about the umbilical vein. Now let me round up by having a look at intrauterine growth restriction in a few minutes and in a few words. The sort of paradigm that's evolving is that there are two sort of aspects of it. Remember in the old days, people used to talk about asymmetrical and symmetrical and all that. That is no longer quite important. Yes, what perhaps is more important is the effect of growth restriction or fetal growth restriction preterm and in the term baby, because it is much more difficult to predict, diagnose in the more mature fetus, but it's probably easier to treat. And there's a trend. I will refer you to two sites at the end of this from which you can gather together quite a lot of information about this so that it adds to the brief taster we have had here. If you look in the beginning, there's placental dysfunction, and this is showed in the uteroplacental circulation. There's increasing resistance in the uterine artery because there's a failure of the second and third wave of excavation that allows impedance to drop and allows blood flow to be maximal to the placenta and fetus. And another sign is that umbilical artery resistance increases. Now, decelerating growth, if there's a fetus that is growing below the 10th centile, you start worrying. And particularly if the abdominal circumference, which contains all the elements, it contains fat, it contains bone, it contains all the elements of human tissue, skeletal muscles, all elements are in there. Therefore, it's a very useful marker for fetal size and fetal growth. As this progresses from decelerating growth into hypoxia, meaning that there's lower PO2, you start to see redistribution in the middle cerebral artery, and then the amniotic fluid volume starts to decrease. You can see that oligohydramnios is a late sign. And this goes on. By the time you get to seeing changes in the ductus venosus with increased resistance, there's acidemia. And those of you who followed the work from King's on fetal growth restriction will know that there was a lot of studies done looking at the pHs, looking at the components of blood gases, and it showed that really there are profound changes that happen with fetal growth restriction that are reflected later on in neurodevelopment. Okay? Now, by the time the acidemia gets severe, you start seeing abnormalities in your biophysical profile, and there's pulsatility increasing in the umbilical. Okay, so people now look at it and say, there's early onset, there's late onset, and how does this sort of affect us? If you look at it, I've outlined it in this slide, and you can follow on that with early onset, all those parameters that I mentioned previously are there, whereas in late onset, it doesn't always show up. You can have a normal umbilical Doppler. However, you are less likely to have an abnormal CPR, and the vessel, which most of us have discarded now, the aortic isthmus, is also useful. Doppler Velocimetry, maybe not. The cutoff, I said, is 32 to 34 weeks. And if you look at Eduardo's papers and publications on their website, this is the Barcelona people, the group in Barcelona. They're well established on the internet. You get a lot of information about it. People talk about pre-terminal changes. I will not go on too much about this because it just demonstrates the sequence of events that I mentioned to you earlier on, from a healthy pink baby to a blue baby to a baby that is pale and dead. When to deliver was one of the biggest questions I've ever been asked, because it's a difficult question without tools that are useful. And every year in Benin, this same question is asked by a lot of people. Ideally, what we're trying to do is balance the risk between fetal death, neurodevelopmental damage, and intrauterine fetal death. In practice, you also have to look at your environment because of prematurity risk and all the other issues. Are there any absolute rules? No, there are no absolute rules. However, we know that beyond 32 completed weeks gestation, like 33 weeks and above, when there's any abnormality in your venous Dopplers, the risk of hypoxemia is so significant that it outweighs the risk of prematurity. Less than 26 weeks in our own environment, only if you have very strong evidence of hypoxemia or fetal compromise should we attempt this, because we don't have enough of neonatal intensive care facilities to justify taking those. So for further reading, these are the two sites. Fetalmedicine.org, they've got calculators and things that will help you in your day-to-day practice in deciding when to intervene, when to deliver. Thank you very much. I think it's now, it's 6 o'clock, is it, or 7 o'clock? I don't know what the time is over there, but yes. Okay, I'm not sure whether I lost everybody at some point. Probably did.
I want to say a big thank you. Please show of hands if you know you appreciate his lecture. If not, then let's just tell him that, okay, next time we won't call you again. Yes, let's see. They are rising, 7 participants, 8, go on. Beautiful, 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 beautiful. Ah, they are rising, they are rising. You soon get up to 100. Ah, that would be a new world record. Wow. I want to say a big thank you to Dr. Leye. As ever, he loves to teach. It's such a wonderful experience that we've had with him.
It is a big pleasure to be, and thank you for asking us all to join you. Thank you, everyone, all Benin people and those abroad.
Thank you very much, sir. So, as we said, Doppler is not what one can learn in one day, but in the last 1 hour, we tried to go a lot. But as I told you, we also have it in, if you go to our website, you're going to find recordings of all these lectures. So we recorded today's one quite early. So in the next 48 hours, hopefully we'll put them in there. But all our webinars are already at our website. So once you get in there, I think at the end I'm supposed to scroll. So we are just at about 4 p.m. now. We planned this meeting to last from 3 to 4:15. So please permit me to just say a few things and then add a few extra things. So we just have about 10 minutes left. But before I go on, I must give credence to a lot of persons who are here. Permit me to just quickly start with one of our teachers, our examiner who was with us last year in Benin, Professor Saturday Etuk. I thank you very much for joining us. And there are so many people from within and outside the country, great men and women. I thank Dr. Obaseki, who recently retired from the civil service as the permanent secretary, is here. Dr. Jerry Waifo is always with us, is here. From Ghana, we have Dorothy. She has always been with us in all our programs. I thank you, Dr. Nzeribe. Dr. Ime Akpan sent me a message yesterday on what she wanted to learn, and I believe that she has picked that up. Dr. Osula. There's somebody from outside Nigeria too, Dr. Ngaya Sudi. Yesterday, incidentally, we had an ISWAG meeting online, and I asked them to also ask some of their folks to join in. So I won't be surprised if that's one of the persons, looks like from the Middle East. Dr. Enders from Liberia, Dr. Odun also from Liberia, and a few others from Liberia, Professor Okonta, and many others. I want to say a big thank you. Professor Buka, I'm going to mention something about that in the next few minutes. Buka from Meduguri is also with us, and I thank him very much. All our facilitators, I see many of them, Janet, Njoku, they are all there, and all our committee members. Thank you very much for being there. So feel free to always contact me or our institution, and we'll be glad to collaborate on that. So Leye, I'll give you just a few seconds. If there are questions that you say, I'm not going to go through them. If there are questions or comments that you want to quickly talk about, I'll be glad to have them.
Thank you. Let me see if I can share my screen. Can you all hear me? But basically, the one pressing question was about ductus venosus and how it affects, what changes you can see in it. And I sort of answered that question a second ago, saying it's to do with the air wave in the ductus venosus, in venous circulation. Sometimes you can have absence or reverse flow in the air wave in the ductus, and this is a poor sign. This indicates poor myocardial function, and you find this in some babies who have abnormal karyotypes. So this is one of the signs that you would find in the first trimester. Later on in pregnancy, the same thing. Pulsatility in the ductus venosus is an indication of coping, and remember what we said about it, that actually it can indicate impending stillbirth, but it's not very good for predicting neurodevelopment. There wasn't any other immediate question. Somebody wanted the materials, and they are available on the website, and the bits that I spoke about as well, the other two sites that I referred everybody. Oh, Janet, thank you very much for answering the question about absent or reversed airway flow. Huh? I think that's about it.
Okay, so I'll quickly just show a result somewhere now. Just share the screen of a result quickly. Let me see. Okay. So now this is a result. As based on this lecture today, I think we'll just have about 2 or 3 minutes. Using the charts, I would like to have 1 or 2 comments. It's a result of a high-risk pregnancy. So just a few comments, but these are things that we're going to discuss in the second or third session. Umbilical artery, fixed systolic velocity. ED, I'm sure that's end diastolic. peak systolic over end diastolic. Uterine artery, the same thing. This one, the same thing. And then for middle cerebral artery, we see an end diastolic of 0. And based on that, listen to the report. This suggests that the middle cerebral artery shows absence of flow in this. This suggests a raised pressure in the fetal brain or increased resistance in the peripheral body, and blah, 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 blah. This requires serial follow-up as it may suggest significant fetal abnormality. Just a few quick comments and then we'll close. As I said, subsequently, we're going to share images and videos, and we're going to learn from them, especially as it has to do with Dopplers. So for any person who probably has looked at the chart, or if you think that you want to speak, just raise your hand and then I will mute you, and then we'll close for today. So let me see if any person, oh, these hands, I don't know why they are raised for thanking him. So if I see a new hand that's raised now, or you want to speak on this, then quickly do that so that we can close. Anybody? I can't see any person here now. Anybody, please? Just unmute yourself. I think you can unmute yourself now since I've asked for it. So if you want to speak, feel free. Okay, Leye, you can just talk there since nobody is talking. Janet is there now. Janet. Janet. Okay, so okay, maybe she's not hearing me. Okay, Leye, comment.
So
I saw you laughing.
umbilical artery parameters. The PI of 40 what?
PS, that's actually PS.
PS of 48.
Yes.
Old age is coming. And an end diastolic flow of 18. And the PS over ED ratio in umbilical artery Doppler.
Yes.
Umbilical artery Dopplers, qualitative is presence or absence or reversal of end diastolic flow and filling. Quantitative, PI. In the old days, RI, but now PI. So I'm not quite sure what this gentleman was trying to describe. Then he looked at the uterine artery Dopplers, he or she, and said, peak systolic in the uterine artery Dopplers of 114. It's a bit dodgy. End diastolics of 51. And then a ratio of 2.2. With the uterine artery Dopplers, again, qualitative, quantitative. Qualitative is presence or absence of a protodiastolic notch, broadening of your protodiastolic area. Quantitative is PI or RI. Nowadays, PI. So again, I'm not quite sure what he's talking about. Middle cerebral artery does not suggest fetal abnormality unless there is a tumor or vascular tumor or growth in the brain, and it will be stated as such. So again, when you look at all the three things in this report, it is a bit concerning that we should have somebody produce a report such as this.
Okay.
It needs
now,
to come to me.
I've tried to make sure that I hide all the details here because this is purely for teaching and training. It's not, in case any person can trace it to any person. This is purely for training. If I had a way, I probably would have produced a result myself so that it would be used for training.
Yes.
Now, just to know that when you have absence of end diastolic flow in middle cerebral artery, many times it's as a result of your technique and not necessarily a show of IUGR or of fetal distress. I've seen this at least twice from reputable areas. So again, as I said, we'll keep learning on all this. I just decided to show this, but as I said, there are a few other things that we obviously cannot show today based on time constraints.